I'm a faculty member in the residency program here for 20 years. I just recently took the role, part-time role, as chair of the family and community medicine department. And Katie is a lawyer, so we'll hold the jokes about doctors and lawyers to the end too, so we're not going to throw out any of those to start with. But we're going to talk to you a little bit today about why Katie has become my new best friend in the care of patients, utilizing a concept called the medical legal partnership. I am having a little bit of deja vu because in 2011 I presented at the FMEC Innovators Conference about a concept of taking care of folks with complex health and social needs. Back then we called them super utilizers. We don't use that term anymore. But it's interesting because Larry Bauer sent an email to some of the folks in our program who sent it out to the faculty and said, hey, there's this guy named Jeff Brenner at the Camden Coalition who's done hot spotting and looking at people who are high utilizers of the health system and how you can, if you deal upstream with some of the social needs that they have less utilization. Is anybody interested in looking at that? And I said, sure. So that started a huge, long process towards developing our high-risk model, which led to developing our population health infrastructure in our health system, and it includes many of the people that are actually in this room. So Larry, I want to thank you for sending out that original email. We think of Lancaster County as being fertile soil, and so this, I think, is an example of how, you know, a little seed can bloom up into something bigger than what it was. So I appreciate being here. So in the past 6 months, has a patient told you about a problem with housing, their child's education, or their job? And what did you do about this info? Has that happened to any of the providers in the room? It happens to me every day, and it probably happens to all of you every day. Health systems are trying to figure out how to deal with this, you know, and there's different ways to deal with it. There's a social worker maybe you can refer to. You can make an ambulatory referral to a social care hub where somebody can get needs met there. And the interesting thing about social needs or social determinant of health needs is that once you identify one issue, it's usually the tip of an iceberg. So these things run in paths. They're not usually one, you know, singular issue that you can deal with. And so when we developed our clinic called Care Connections, which looks at folks that have higher than what we would think of normal utilization, we had to come up with an integrative model with a team, including our legal consultant, Katie, to try to figure out what are some of the ways in which we can think about dealing with these issues in a different way. So medical legal partnership is a broad term. There's a National Center for Medical Legal Partnership, and basically it's an intervention where legal and healthcare professionals collaborate and help patients resolve these social and environmental factors that contribute to health disparities and have a remedy in civil law. So I'm going to pass it over to Katie, and she's going to talk a little bit about how lawyers deal with issues such as social determinants of health.
So as Jeff said, I'm Katie Schultz. I'm a legal aid lawyer. I have been, first of all, let's think to get some context. How many people in the room are familiar with civil legal services or civil legal aid? Okay, so just a little nutshell sort of background on who I am, where I come from. The lawyer in medical legal partnerships is sort of not just any lawyer. That resource tends to draw from the world of civil legal aid. And civil legal services are a network of nonprofits across the country who provide services free of charge to low-income folks in civil matters. So most people are familiar with the concept that if you're poor, you get a free lawyer if you're charged with a crime. That's in our it's a constitutional right. There is no corresponding right for poor people with civil legal needs, and often those can be as sort of critical and life-sustaining as being accused of a crime. If you're losing your housing, if you're losing your health insurance, if you're a victim of domestic violence, if your kids are taken from you, I mean, these are all some pretty critical needs, and there is no guarantee that people are going to get help with that if they can't afford legal assistance. So civil legal services try to, as best we can with the available resources, provide some of that critical legal care. So that's where I come from. Mid-Penn Legal Services is an 18-county program. We cover most of South Central Pennsylvania. I'm based in the Lancaster office, which is just across the square, right behind the courthouse. So really conveniently located for people who can walk into our office and apply for services. As we'll talk more about what we've done here in Lancaster with Care Connections, this medical legal partnership really helps me to reach patients who are never going to come downtown and walk through our doors to apply for services. So anyway, this chart sort of shows in general with medical legal partnership some of the ways that legal services lawyers can help with some of the problems that your patients are presenting to you every day. We divide it into these broad categories using the iHelp mnemonic: income and insurance, housing and utilities, education, legal status, and personal and family stability. In the complex care setting, I am by far the majority of the cases I'm dealing with are in the I and the H categories. So income supports housing related needs. And this is from the National Center for Medical Legal Partnership. There's a slowly growing body of research on sort of the value of this intervention, and just summarizes some of the research that's out there. Fewer hospital admissions, better adherence to medication, less stress, cost savings. These are some of the benefits that we're finding do go along with medical legal partnership. And there's, I have at the end of the presentation, the website for the National Center for Medical Legal Partnership, where all this research can be found. So that's sort of medical legal partnership and civil legal aid in a nutshell. Jeff is going to transition to talking in more detail about specifically how we've developed this in Lancaster County and integrated legal care with the complex care team.
So Lancaster Medical Legal Partnership's been around for a long time. The innovation that we had was to integrate it into the care of persons with complex health and social needs. We think this was the first time this was ever done in the country. And we did it in a different way, because normally what happens is you would refer to a lawyer who was off-site. We decided that it was really important to bring the lawyer actually into the healthcare team. So Katie got completely integrated, even to the point where she had read-only access to an electronic medical record. This caused a little bit of consternation in our health system, as you can imagine, with our legal counsel. But our legal counsel had actually done some civil legal aid work, so she understood what we were trying to do and was okay with it. So medical legal partnership's been around since '93, but we kind of took a different spin on it. We began in 2011 with our super utilizer pilot, which was based on the work of Jeff Brenner and the impetus from FMEC. In 2013, that project became Care Connections. We actually integrated Katie in with the original pilot because we thought, as part of our multidisciplinary team of caring for folks, the lawyer should be at the table. We published a health affairs article about our initial data. You can take a look at that. And in July of 2015, we received a rather substantial United Way grant, which helped to fund the work for Katie, helped to fund her services for the next 3 years. At the end of those 3 years, United Way, even though they said we met all their metrics and we were the kind of the star of the United Way Impact Program, and we gave talks about how well we integrated together, we were defunded. The reason we were defunded was because they said, you're part of a health system, the health system should be able to support this. We're going to support nonprofits in the community that don't have other sources of funding. So since that time, we've begun a journey of trying to find outside and internal funding for Katie's work, and to kind of continue the process and think about using medical legal partnership in a unique and innovative way. Care Connections is a team that's an intensive care management multidisciplinary model. We become the primary care provider when we identify people that have more than expected utilization. They come into Care Connections. It's a family practice run office, but it has a lot of services, as you can see up there, that aren't necessarily in other regular clinic spaces. People are with us for about a period of 6 to 9 months, and then they transition back to their primary care provider. And we've learned a lot, not just about the care of persons with complex health and social needs, but we've learned a lot about team-based care. We've learned a lot about other innovative ways that the health system can surround people in a population health way to care for the needs that they have. So the legal services were intimately embedded in our care model. Again, most of the consultation in medical legal partnerships happen off-site. We brought Katie into the hospital, into the team, and what happens, a lot of the consultation actually happened organically, so that when issues are discussed every morning in our morning huddle, which is 30 minutes long, then issues from people that our care navigators or care managers have been thinking about over the past several weeks rise to the surface, and Katie can intimately be involved in the discussions about how to care for those folks. So we're having high-level discussions about clinical care, we're having high-level discussions about dealing with social needs and social determinants of health. So every morning we meet, Katie's a part of that, and that's a lot where a lot of the issues rose to the surface. So we did some study of some of the issues that we've come up with, and I'll pass that back over to Katie to let her tell you about that.
Yeah, so we just, this was in the first 2 years of this partnership. I did some pretty in-depth screening of legal needs at the time that patients were enrolled into Care Connections, and did find that this might vary by area. I think there's certainly other parts of the country, there are even other parts of the state where you might have a much higher incidence of problems in the the legal status category around immigration needs. But here in Lancaster, the vast majority was in the income, insurance, income supports, going along with people's health really declining and financial chaos erupting, debt collection, inability to afford prescription co-pays, food insecurity, all of that, losing their utilities, all that lumps together, and then in turn leads to housing instability. That's really where we found the concentration of legal needs in this population. And interestingly, there's also a very successful medical legal partnership in Chester County, Pennsylvania, that's originates in the Widener School of Law. And they have focused their work on Healthy Start and nurse-family partnership, and actually find the same sort of distribution of legal need. You would think, pregnant and parenting moms, it's going to be custody. Certainly there's that need, but again, in terms of what's driving, health, it's income, and it's the I and the age. So that's what we're actually just starting a pilot with Nurse Family Partnership and Healthy Beginnings here in Lancaster, and we will be focusing there also on income supports and housing needs. This is some of the data I've been able to glean from my work with the patients I've worked with directly in terms of benefit. So this is not looking specifically at benefit to the health system, but at benefit to the patients. So I can sort of try to quantify what's the value of the service I provide. And what we find is that the average benefit from getting someone health insurance, getting them SNAP, getting them Social Security disability, where they've been denied and need to appeal, getting them into safer housing, keeping their housing, the average benefit per patient client is over $6,000. So in the 4 years that we've been operating, we've reaped benefits for our patients, almost over $850,000. And then just to compare that, the average cost of the services of a legal services attorney to defend an eviction, prevent a foreclosure, appeal a denial of a benefit is about $770. So that's the average. In some cases, I might give someone an hour's worth of advice and that's going to solve the problem. In others, if I'm going all the way to a Social Security hearing or appealing something, that can be substantially more. But that's the average. So a pretty significant return on that investment in legal need. And I think it's just important to point out that the resources of the existing civil legal aid network are not adequate to meet the need out there. Legal services at their current level of funding need to turn away about half of applicants. So we're only meeting half of the need of the people who make it to our doors to apply for services. And again, in this medical legal partnership context, integrated into the healthcare team, where it's certainly outreach where we're reaching people who never otherwise would have even applied for services. So this is definitely a needed expansion of the available services. The other role that the legal aid attorney can play in a healthcare team is in education. So it's sort of really spreading that benefit and assisting the different members of the team in working to the top of their license, and working more efficiently, working more knowledgeably, really tackling some problems that don't necessarily require a lawyer. So just an example, that's me training the team, lunch and learn, I do a lot of those, and we were talking on that day about energy assistance. It was probably November, we were getting to the season when people need heat, and I was talking about the different tools and tricks available to help keep people's heat and lights on.
So what is the benefit to the healthcare system? It's a little hard to tease out because we have multidisciplines that are working within Care Connections, and Katie is just a piece of that. But, and now we have about 6 years of patients who worked through about 700 patients over that time period. We look at what was the utilization 12 months prior and 18 months afterwards to try to get away from regression to the mean to make our numbers look good. Obviously, we take out people that died in our program because their post-utilization looks really good. But as you can see, even though we don't really target ED visits, we decrease utilization by 44% and inpatient visits by 56%. Cost to the health system is a whole other animal. It's hard to look at, try to actually figure out how much cost you're savings in terms of what the health system is getting in reimbursement. So we've chosen to look at charges. Now I know charges are not necessarily based in reality, so it's not so much the numbers that you're going to see on the next slide, but it's more, I think, the percentage of the cost reduction that you see in these folks pre and post intervention when they come through Care Connections. So we've historically seen quite a bit of drop in overall spend with this high-risk patient population. So what are some of the lessons that we've learned through this now about 8 or 9 year process? We know that legal issues are common. We know that they go along with complexity. And 95% of our patients have 2 or more identified legal needs. So it is a population that is at risk from a legal standpoint. The vast majority of our patients have never accessed civil legal services. Well, why is that? Well, it's because the same reason that prevents effective engagement on the healthcare side also prevents somebody from figuring out that there's a legal aid office. They need to get a car, it has to have gas in it, they maybe need some help getting there because they have some mobility issues, and then they have to make it to the office, which is the traditional model of how legal services have been provided in this country. So having somebody at a point of care when somebody already comes into the clinic, like Katie, takes care of that problem. Just like we try to take care of a lot of other issues at point of care, so we're not having our patients who already have 18 specialty visits and lab visits and physical therapy visits have to have one more visit off-site. The final common denominator, and this is interesting because we're all talking about it, is housing, okay? Healthcare, increasing healthcare increases your financial risk. The more utilization you have, the more financial risk you have. The less you have the ability to pay for things like, we already talked about how much rental amounts each month are overwhelming the total amount of an average person's budget. So there's very thin margins out there, and even if you have $2 or $3 co-pays, that pushes people over the edge. If you can't get the benefits that you need, it pushes you over the edge, and then all of a sudden you can't be housed. Well, I think it's safe to say in this day and age that especially with folks with a lot of complexity, without housing, you can't do much in terms of engagement. Housing has to happen first before you can actually find those people and help take care of some of the issues that they have. Integration within the team was the primary key to success in our model, and 89% of the patients reported reduced stress as a result of receiving MLP services, just like the previous presenters. When you reach out to people in that way, they're very appreciative, and they completely thank you basically for the work. They're not used to doctors kind of doing this kind of work, and they feel much better as a result. So how is this funded?
All right, so we talked about how this is funded in Lancaster, and since losing since the end of that 3-year United Way grant, the Mid-Penn Legal Services has been doing fundraising for the project, and we've also worked collaboratively with the health system to find some other sources of funding, foundation funding and other grants. So this is just an overview from the National Center about how different projects are funding this around the country. About 38% of healthcare organizations are contributing some funding to Medical Legal Partnership for those who have it. A lot is coming still from external grants, foundation, community benefit funds, and other charitable donations. So there's a lot more information, again, on the National Center's website, sort of about funding and potential sources of funding for these projects. There's also a slew of resources about starting these, all the sort of nuts and bolts that you might want in putting one of these together. So it's a great resource if this is something you're interested in pursuing. So I think we're done and on to the questions portion.
Actually, we're going to hold questions. Do you want us to hold questions to the end? Or?
We've got a couple minutes. We've got about 5 minutes to take some questions.
Okay.
So, I would love to help me differentiate social services and legal services. So I saw that wonderful chart, the services you provide, and I said, gosh, that's who I used to send people to a social worker for. And so, are they a member of your team, and that's what we're doing when we send them to you?
So it's not a bright line, and I think that the social work, legal services collaboration is a really critical part of a functioning medical legal partnership. And so in Care Connections, there's social work and there's also patient care navigators. So there's sort of a variety of professionals, but it can be tough to figure out. If someone has been turned down from a benefit just because they didn't file their recertification paperwork. Every year for food stamps, you have to re-verify your income. That's pretty easily solved. It's not necessarily a legal need. It can get, if they're being accused of hiding household members and not reporting income that they had, and you have to file an appeal, that's getting a lot more complicated. We're talking evidence, we're talking liability, and then it sort of goes to the lawyer. So it's a great way to set these up, is to have sort of the lawyer and social worker as a team, and they can kind of triage.
Well, and the care navigators. We've elevated the care navigators to be sort of social workers to a point where they know this is the right form to get, this is the right place to send somebody, this is the way I need to set it up front so we don't have any back-end problems. But even the doctors end up having more of a legal mindset, because when you're certifying somebody for disability, it's really nice to know from a legal end what are the things that they're going to be looking at in order to do that. So it's, we're not lawyers, but I certainly understand the benefit of having a lawyer, and that's why Katie's become my best friend here over the past several years. So.
One other, just to that also, we actually did really think about this closely in setting up our pilot with Healthy Beginnings and Nurse Family Partnership, because I think the example I gave was public benefits. There's a lot more gray area there. If you're dealing with housing, custody, PFAs, protection orders, those need to come to the lawyer. So there are definitely areas where non-legal professionals sort of dabbling and giving advice can be, and that's something that when you set one of these up, you really think that through and set your referral protocols.
How many other types of special knowledge do you have on your team? I think you mentioned social workers, you mentioned behavioral health psychologists.
We have a psychologist, we have integrated behavioral health, we have social work, we have care navigators, which is really what I call they're the primary care providers for these patients. So they're in the home mostly, they're triaging issues, they're out of the office, they're visiting their panel of patients that they have. And then the other innovation is our care managers manage both the inpatient and the outpatient setting. So they walk through both of those sectors of care. So what we've been doing in a high level in the outpatient setting, that knowledge gets transmitted when our patients get admitted. And the same care manager is dealing with the issues from the inpatient perspective.
When
So
you're saving all this money for utilization of ED and hospitalization, who actually is benefiting from that savings?
John, you want to take that? So a lot of it is the insurance companies. We talked when we went on this journey that we were going to be in a total value-based arrangement, right? We all thought that 7 years ago. By now, we're going to be able to, like, any money that we save, we're going to bring back to the health system. That hasn't exactly panned out, but there are, we have an ACO, there are at-risk contracts. And the other thing you need to think about is the upfront spending in a lot of ways is research and development for new care delivery models. So we don't think of hospitals necessarily as providing research and development, but it really has been. We have people from all over the health system that come through, rotate, see our model, understand what it's like to care for complexity, and then we can push those people back out into the health system. So there's an added benefit that's a little hard to quantify from a sheer cost amount.
But this would make most sense in an accountable care organization or
If you were it makes most sense when you're at risk.
Last question.
Okay, one quick question, similar to the others, but on a different level. How have you been able to, if you've been able to, work with other
organizations in the community and leverage resources to, one, expand your network, and then and also expand the opportunity of reducing systematic costs.
Yeah, so one of the ways that we found out is that a lot of times people are losing their housing just because of inability to pay the rent. You can't legally justify keeping somebody in their home. So we partnered with a local housing agency, and we had what we call the protective financial case manager. Knowing that people with complexity are going to be at high risk for financial problems, that if you can get somebody that comes in, looks at their debt load, looks at their income, establishes a budget, that they're going to be more likely to stay housed, and we're going to be still more likely to engage. So that's an example of how, you take some of the information that Katie has gleaned, you grab a community organization that's doing great work with this in the community, and you match that up.
And just, we've also, I think, just through, Care Connections, we really are, I know that the healthcare team and I all together are working better or more closely collaboratively with the Office of Aging, with Adult Protective Services, with the sort of financial services. So I think that I do see, increased efficiency in terms of not everyone trying to tackle the same problem separately. Yeah.
Thanks.
Thank you, Jeff.
Katie.
So at this point, we're